I'm absolutely honored to be here. I appreciate the invitation to be part of this wonderful event for a wonderful organization. My topic today is COVID-19, caution, connecting, and caring. I was initially going to speak on the original invitations about like the science of COVID, but I know that we're all pretty tired of that. And what I really was interested in is sort of how we can get past the science and get back to some semblance of a normal life and normal connections. So bear with me, and I will talk to you for the next 15 or 20 minutes about my experience as a COVID transmission MD, what I've learned, what I tell our healthcare workers, but more importantly, some of the science of love and connection and how I think they can overlap. And so for disclosures, you had a background intro from Ms. Lee. I appreciate that. I'm a recent advisory board member for Care Indeed. I don't have any financial interest in any companies or products that are mentioned here, including the company itself. Well, 2020, so here we are. We are shackled and bound and restrained by this COVID-19 global pandemic epidemic. And yet we are also lost. There's this New York Times Magazine cover that I thought was so poignant called The Lost Years. They actually did 4 different covers on this particular week. And I just liked this one. You see the loss in the eyes of this boy who I feel like is on a school bus and maybe should be going to school, but he's behind a shirt and behind a bracelet and behind a mask and behind a window. And looks to me like he's looking out on the world as we all are, wondering like, when am I going to get back out there? When is it going to normalize? How has this happened? And I certainly don't have the answers to all of those, but I know that we're all feeling a lot of the same things that he is. We've all suffered quite a lot of losses this year through this global pandemic, and most particularly the loss of lives. And for anyone in our audience who has lost a loved one, my heart goes out to you. We're not over it yet, but we're definitely getting better at managing it. We've also lost school and we've lost work. People have lost their jobs. And of course, there's this physical component to our lives where we lost hugging each other and touching each other. We've lost holding hands. We've lost dancing. We've lost all sorts of physical interactions that we used to have. And I think sort of on an even bigger scale than that, we've really lost a lot of our connection to each other. I think that is across particularly our United States. And in many ways, I feel like our country has lost its connection with itself. And when it was the leader of science in the world, when it was the exemplar of how to handle strife and burden, when it was the welcoming melting pot of the world, so much has changed. So how are we going to get back to connecting when we're behind all these barriers and when those barriers are what is supposed to keep us safe? And more importantly, why does it matter? Why, as a physician, am I bringing it up to you? Well, there's this great paper, as well as thousands of other papers, that really show nicely the Proceedings of the National Academy of Sciences is one of the most prestigious medical journals there is. And there's this nice article. You can go look it up anytime you want. I put the references throughout this talk. But there's 2 decades of research that show absolute causal relationships between strong social relationships and mortality, which is death. So more social relationships, longer life. It's actually longevity. And this analysis that they talk about in this paper is multiple dimensions of social relationships, whether it's familial relationships with your siblings, whether it's romantic relationships or social connections. There are nunneries in the world that have the longest living people on earth. And that's felt to be not the abstinence of behaviors, but in fact, the social connections they've made with their sisterhood. And not only do people live longer, but the association is with robust health. So these social connections are as important as any medical connection there is. And conversely, the data shows that the lack of social connections is associated with vastly elevated health risks, and that the negative effects of social isolation actually exceed that of clinical diseases like diabetes. So if you had to choose one, in this case, you'd rather be an older person with diabetes than socially isolated, which makes the system that we're in right now particularly concerning. Here's an interesting article this summer in the New York Times. The title of it was "Continued Bans on Nursing Home Visitors Are Unhealthy and Unethical." You know, the blanket bans that were placed on in-care facilities, they all have different names now, community living centers or SNFs, skilled nursing facilities. These bans were blanket bans on all visitors, and they really failed to capture how friends and family are critical to our loved ones' care. The caution in having visitors in these places is understandable, but caregivers, they make sure that patients eat and that they can communicate their needs and they have appropriate hygiene care. And oftentimes these visitors are the first to see changes that happen. And patients without visitors are well shown to have a decreased quality of care. The Medicare standard, the CMS on May 20th, actually changed for these skilled facilities, May 20th, and said that if these facilities didn't have any COVID for a month, and if they had appropriate PPE, personal protective equipment, that they could reopen to visitors. Otherwise, they'd only be open for end-of-life care. And so many of these facilities have not reopened and are still closed and only open to end of life. And this picture is just heartbreaking. It's better than nothing, but it's heartbreaking. One quote from this newspaper article is, "The sudden disruption in residents' contact with loved ones has caused notable declines in residents' cognition and function, depression, as well as anguish for family members." And I know people out there in the audience will have family members in these places and are, as my friend said, who works at Care Indeed, grateful that there are limitations so that they can stay safe. One has to hope that within those facilities, the caregivers are providing the care and the stimulation that's needed by our loved ones who are at home. And that's exactly what Care Indeed home health givers give. They act as friends and family for those of us who are too far away from our loved ones to give that social interaction ourselves. So I think home health care is a real blessing in this setting. So I'm going to jump to that science of COVID that I mentioned, and I'm not going to be super sciencey, but I want to just kind of myth buster. Let's talk about what you're hearing about in the media, what is happening on the news. I'm just going to go with true and not true, and you can fact check me later, but all the facts are so conflicting that you might just kind of have to trust me on this one. So here's one of my main things. Okay, what is with this social distancing? It shouldn't be social distancing. That is inaccurate terminology. That is not scientific terminology. It is harmful. That term arose prior to us even having mask wearing. It happened really early, like in March. And that term, social distancing, increases isolation. I like this image above where social distancing is you got somebody in a mask and they walk by you and the question is, well, do I say hello to them or I turn away because I'm going to be socially distant? Do I give them the stink eye if they walk near me? I really feel like it's created a very negative atmosphere when the correct terminology should have been physical distancing. And it's what we've changed all of our signage to in our hospital. It's the language that we're now used to using in our hospital. It's physical distancing. It's not social distancing. And physical distancing is particularly important indoors and in small areas like locker rooms and break rooms or cafeterias. That's when you need to be really away from other people because that's when they're taking masks off. But physical distancing outdoors is also not scientific. So don't stress if somebody walks past you in one direction or runs past you or crosses, or, if you're in a grocery store and you're checking out and you're not, completely physically distant from somebody, if you're both wearing masks, just be mindful of that. And I'm going to come to it again in a minute, but let's remember that we need to make social connections in this time of physical distancing. And we do that through making the connections that we used to make, but even making more of an effort to do that, to look at people with their masks, look at them in the eyes, smile, laugh, tell a joke, cherish each other, and remember that you're increasing your own and others' life expectancy when you do so. So I kind of mentioned this 6-foot recommendation. So this is another thing that came out before masking. The 6-foot thing is not science. It is a general blanket statement that came out to speak to the lowest and most common denominator across the country. The deal is COVID-19 is still a droplet disease. The droplets, my spittle, our spittle, when we talk or when we yell, if one were to have COVID-19, those carry the virus. It then lands on a solid surface, and the next person who touches that surface within a close time frame can pick it up and transfer it hand to mouth. It is still not an airborne disease. Airborne in the scientific term, that it's not floating around like smoke particles just did when they blanketed California. They are carried in the air as long as my droplet can fly, which is generally thought to be, with normal speech, approximately 2 to 3 feet. So when the 6-foot thing came out, the idea was kind of another scientific standard, which is that you do one standard deviation beyond safety. So if one standard is 3 feet, then one extra standard deviation would be 6 feet. So it's just a blanket. It's kind of this, as this little blurb says, an outdated dichotomy model that isn't really the science. That said, some level of distancing is important. And this British Medical Journal, the BMJ, is a really good journal. I have other ones here. You have to be really careful what you read. These pre-printed ones in journals that are not peer-reviewed, these papers that come out that talk about just one patient are irrelevant. But good journals like the New England Journal and BMJ and Lancet and the Proceedings of the National Academy are ones for you to refer to. So anyway, this was a study in 149 countries that implemented physical distancing. And interestingly, the paper uses the term physical distancing. And it shows that there is a decrease in, there is an overall reduction in COVID transmission. They show a relatively modest one at 13%, but remember, when you're going between 149 countries and they all have different levels, the point is that you do want to maintain physical distance from people who you do not cohort with. That's for sure. That means don't get in a car for any prolonged period of time. Mass public transportation like airplanes, where the air filters are really good, are actually looking to be pretty safe. Public transportation was actually called out in this paper as being safe, buses and airplanes. But I have already seen transmission happen among our employees in minivans and in cars, and certainly in break rooms. So again, physically distance, but please no stink eyes, no social demeaning of people who walk by you or are standing at the checkout counter, closer than the big red X on the floor, because this is more about mindfulness than a particular metric. So can we avoid COVID? Yeah, again, I'm talking about this because this is just a virus. Like, it's this little thing. I totally admire it because it found a way to sweep the world. And this little tiny RNA particle has really found a way to propagate itself. But it's just a virus. Like, we get it. You can protect yourself from a virus with the same things that we know: distancing, masking, like we've been doing for so long, and hand hygiene, which we'll get to. So masks work. I love this guy over here with his coffee filter. I thought that was pretty funny. So masks work, and they work best when both people are wearing masks. We have had transmission in our hospital when one COVID positive patient is not wearing a mask and the healthcare worker is, and we've had it in the reverse. So I really prefer that both people, if there's a chance that there is COVID infection, are masks. Maintain distance as best you can, and the mask type should be a double layered cloth or surgical, or the KN95s or the Korean N95s that are out and they're more available now to people. You should not use masks with exhale valves. You don't have to use these ones with big old filters put inside them and stuff. There's no science that shows that a surgical mask versus a KN95 actually makes any appreciable difference. If a N95 is fitted really, really well, it could be 1 or 2% better. But we've been wearing surgical masks in hospitals forever with patients with infectious diseases. So yeah, wear a mask. And this, I know this is a horrible picture, but I thought it was really interesting. These are actual plague doctor masks from the 1600s. And in that long beak, they would put herbs that both smelled good, but that also were felt to be like medicines for the doctors who were wearing them, caring for these plague patients. What I thought was interesting, and the reason I included it, is that the eyes were covered. And so they didn't necessarily know germ theory, but they actually covered their mucous membranes, all of them, which I just actually thought that was very interesting. I'm sorry it's a little bit of a disturbing picture. Certainly the mask evolution of what we have now is better. So looking here at some old ancient Roman art, this is a picture of a physician, and he, I guess in this one, is steaming the utensil he's about to use. This is long before germ theory. That's not sterilization, but there has been a concept of being clean in medicine for, hundreds, if not thousands of years. So certainly hundreds of years. So there's this other little sign from Texas that I loved. My hands are consuming more alcohol than my mouth. And I think that early in the pandemic, you might have seen a lot of like empty alcohol cartons on the side of the road. But now we should probably just be moving on with our lives and continue to wash your hands, using hand sanitizer, making sure you get in between the gaps in the fingers, getting the backs of the hands, and really avoiding touching places with bare hands that are touched by lots of other people. I think of gas pumps and obviously door handles and the washers on the cars. So what you can do in that case is you can wear cloth gloves, because cloth can't transmit the virus, only solids do. So you can sit on someone's couch and you're not going to get the virus. You can wear their shirt. You can, any sort of material object. Cardboard is not a problem. People were really worried about the things they bought in grocery stores. Mail, paper doesn't transmit it either. But solid things do. So those vinyl gloves, you could pick it up and touch your mouth inadvertently. But I don't think anybody's going to put a cotton or wool glove in their mouth. So wear gloves when you're out. Use a lot of alcohol sanitizers during the day. Okay. I'm sorry to run too long. I'm going to try to be quick. So I want to bust some myths. What's this whole asymptomatic spread? That's another inaccurate COVID thing. In medicine, this is pre-symptomatic spread. We don't know about asymptomatic. And someone could argue with me and talk about, prisons and cruise ships, but I'm really talking about our general life. When what happens is we know that there is pre-symptomatic spread, and that's the scientific term. So at 1 to 2 days before symptoms, people are highly infectious. So here's the blue man who has COVID. And then the next red man is the person who got sick with symptoms. And the red circles I have there is the 1 day before the red man got symptoms. He, because these happen to be men, it looks like, passed it on to the yellow guy. So 1 day before symptoms, that is pre-symptomatic. They don't have symptoms at the time, but that is not asymptomatic, just so you know the terminology. And that's almost half the transmission is about the day before. 30% of the transmission is the first day of symptoms. So the day before, the day people become symptomatic, and the one day after are their highly infectious stages, which means if somebody had COVID 2 weeks before, you don't have to worry about it. I have a friend who couldn't get a dental appointment because she had had COVID 3 months earlier. Once you are not in the infectious stage of COVID, you are not infectious. One is not infectious. They are not infectious. So there's this tight window of about 10, can take it out to 14 days. But, and I have seen two people on the day 14 who seem to have gotten it, but by and large, it's about day 3 to 7 when really people get sick. So I have never seen asymptomatic spread. We've tested thousands of healthcare workers who are front-facing with COVID people. We screen them. They are never positive if they're asymptomatic ever. So that's what we do when we know that somebody was exposed. We take them then out of the public. Like if your housemate has COVID, that's why the members of the house have to stay home, because they get exposed and 3 to 4 days later, they are infectious, even though they don't feel their symptoms till another day after that. Okay, this it has words on it, but I'll be quick. Is reinfection possible? So I mentioned my friend who had COVID in March. Like, should we be scared that she's going to get it again? Well, there's like 26 million cases in the world so far, and there's only 2 convincing reinfection cases. One was from Hong Kong and one was from Nevada. And we know that they were reinfections because they sequenced the genomes, and they were like the little pink COVID up there and the little green COVID up there. They just were not the same virus. They had enough differences in their genome to conclude that they were different. And so there's 2 proven cases. So that, I would say, at least is very infrequent, of 26 million so far. Maybe there'll be a few more, but it's certainly not cause to worry. And in fact, I bring it up because I want it to reassure us that once people are positive, they kind of enter the safety zone, and we don't have to worry about getting it from them or them getting it again. Super quick, is COVID mutating? This is a big topic when people are talking about vaccines. It does mutate, but we don't have a vaccine for HIV because it mutates like wicked fast, but COVID does not. So there is this one mutation on the spike protein that's really interesting. We noticed it. It was noticed. I didn't notice it, but the people in charge noticed it back in January and February, and then it took off, and now it's almost 100% of COVID infections that are sampled worldwide have this one mutation. It's in the spike protein that you hear about, which is the one that we'll make a vaccine against, but thankfully it doesn't change the spike protein enough to harm what would be a vaccine. And what it's done is it's mutated to actually make the infection spread more easily. It helps it get into the cell where it's going to replicate. So remember, you come in contact with somebody with COVID, you breathe in that cell, and then the cell, spike protein gets into your cell, and then it turns your cell into a virus machine, and that cell bursts and a bunch of virus comes out, and then those infect other cells, and then those make virus and they burst. And that's why it takes about 5 days from when somebody was exposed to when they actually get sick, because their body has to build up enough virus. And that's why if you think you come into contact, don't get tested the next day, because it's going to be negative because your body hasn't made enough virus. You have to wait 3, 4, 5, 6, 10 days before you get tested to have an accurate test result. So the great thing about it is it doesn't make people any sicker. So it doesn't cause worse disease. It just spreads more. And it, since it took over and it's so well liked by the virus, it actually is going to be one of the new targets for vaccines. So last bad slide, I think. How bad is COVID? Bad. I mean, we've lost almost 200,000 lives in the United States. 42% of those have been in the long-term care facilities. That's a huge number. The overall fatality rate for COVID is actually less than 1%, though. It's closer to 0.5%, which is good. It rises in the elderly. In the over 80, it's the mortality rate is about 1 in 15, which is much higher. But in children, just so you know, like, it does not cause death. It can't. Out of 26 million, you can find a few, but the fatality rate in children is 0.0016%. So they're safe. And that actually has to do with the cells in their lungs actually not being mature enough to take in the virus and really host it. So that's kind of interesting. It's their ACE2 receptors aren't formed. So then hospitalizations, about 1 in 5 over 80-year-olds were hospitalized, and about 1 in 100 under 30s. And I should have told you that this is a big study from Lancet that was done in China, and it was done in April. So some of these numbers will have changed. They will have gotten better as we've learned about the disease and how to treat it. Okay. Final question, when is that vaccine coming? AstraZeneca's vaccine, you might have heard, just got pulled from its phase 3 trial. There was, I think it was a single case, but of a very rare and a very serious neurologic disease. And that kind of reminds you of flu vaccine and when it used to cause Guillain-Barré back in the 1970s. So that one is probably going to have to be shelved. The Pfizer one is in phase 3. There's 3 stages of testing. Phase 1 is the first level of trial where the vaccine is given to a small number of people and seen whether it's safe. A phase 2 trial is the dosing stage, where it's given to a slightly larger number, say it's 100 people, and 30 get one dose and 30 get a higher dose, and then 30 more, 33.3 get the highest dose. And that's a dosing trial. And then phase 3 is when you've decided it's safe and you've figured out your dose. It now has to go out in vaccine trials to tens of thousands of people. Like, they have to be enormous trials for vaccines to actually prove a difference, because still in the United States, 96% of the country hasn't had COVID. And so it's not easy. You have to vaccinate an absolutely enormous population to be able to show a difference in whether people are getting it or not. And there's like 5 others, Moderna and these others, that are getting close. But the reason I bring this up in particular is because just a week ago, 9 pharmaceutical executives signed a pledge not to accept the early use authorization that the FDA and President Trump are pushing. Remember, they pushed through this hydroxychloroquine and this convalescent plasma, and they were both disasters. Hydroxychloroquine actually increased mortality. There were plenty of warnings from the clinical community not to do it, but it was pushed ahead by government officials and not scientists, and it didn't go well. So imagine these pharmaceutical executives who have these vaccines, they stand to make jillions of dollars on an effective vaccine, but they're wise enough to know that if they do harm, it's going to be horrible. So they signed a pledge not to accept emergency use authorization. They agreed to what the FDA is requiring, that the phase 3 trial has to show a 50% reduction in disease or in fatality. And that's a reasonable bar. The flu vaccine is usually about 67% effective, so 50% is certainly better than nothing. Back to the beginning and just to the last couple of slides. So now you know about COVID, how it's transmitted, how you avoid getting it. It's just a little virus. We can do it. We can stay away from it. And we can keep your loved ones safe as well. And knowledge is power, and there's Cupid in that picture. So we're going to move to love. Cupid there has all power. We can and we must connect in this time. 2,000 years ago, Plato said, the God of love lives in a state of need, like hunger and thirst. And I think this is so powerful. Love lives in a state of need, like hunger and thirst. It needs to be constantly replenished. People need to be praised and loved and cared for. And that love is built deep down inside us. It's these neurotransmitters in our brain. It's age old. It probably goes way back to survival of the fittest and the need to create offspring. We have 4 neurotransmitters. They behave differently with different types of love, but they're all deep in our brains, and they're built in. So I want to show you a 30-second video, if I can, of something that really impressed me a few weeks ago from Nova, and it's about dogs, dog love. Okay, so just 30 seconds. Bear with me. Sorry.
Gregory has conducted this experiment on numerous dogs. dogs' brains do when they're anticipating food. It isn't showing very much happening, which means that on average the dogs probably didn't care as much about this as we thought. Now we actually do see quite a bit of activity. What that speaks to is the fact that praise is very interesting to the dogs.
Scans show unambiguously that most dogs love praise just as much as food. Some dogs love praise even more.
So that is not relevant to my dog. He definitely loves food more, but I thought it was, I think it's just a lovely physical depiction of what happens in our brains when we care for each other. This is my favorite image of the year. Not a good year, but a beautiful image of a parent and a child. And it's an fMRI overlay, functional MRI, showing the concordant areas of their brains that light up, even in the baby, the same areas when they are loved. So I think this is the final-ish slide. It's a balancing act, and I'm just going to read you the sentence I wrote because I'm so impressed with this company, but whatever company you're with that's providing home health care. I said, I don't have a dog in this race, but I really believe in people staying at home and being cared for when that is possible. So Care Indeed's mantra is that they are the heart of home care. And that, I really think that says it all. This is an organization that understands that now in particular is a time of profound loneliness and isolation for many, including our own loved ones. They are the people who dedicate their lives to care and to adding that heart to your homes. The presence of caregivers who spend time connecting with your loved ones can be as important as food and water and medicine and masks. So there's a scale down here that shows that we find that medium. We have to move from the red zone on the left of social isolation and loneliness and the lack of connectivity to the middle, where we can be safe with just some simple interventions from COVID-19, and we can avoid the isolation and loneliness. So I'd like to see us all get there. Final slide. So let's not allow ourselves to be socially distanced. Let's physically distance and wear our coffee filters and allow our hands to absorb some alcohol, and let's connect and care indeed. And that's all I have for you, and I appreciate your time. And my congratulations go out to the Care Indeed staff for building really a marvelous community of hearts and souls. And thank you all, and be well. And let's hope 2020 goes away pretty soon. Take care.